Hi, Dr. Goldstein. How are you?
I'm good, thanks. We've been busy today.
We've been really busy today. It's great to be in LA. Right now, we're actually at Beverly Hills Fertility, which is awesome. We have a very special episode today with an expert when it comes to reproductive medicine, someone who's done over 1,000 IVF cycles.
That's probably old.
Probably
old?
like
2,000.
2,000 IVF cycles, even better. Dr. Goldstein, so thank you so much for being on High Alchemy today.
Yes, it's very pleasure to be here on the day that we are launching our partnership, Beverly Hills Fertility and Nucleus.
Absolutely. We are so excited to bring Nucleus Embryo to the clinic and to help fundamentally patients have healthier children. Before we get there, though, I want to ask you a little bit more about your personal story, right? Ultimately, when someone is doing IVF, there's so much emotion, right? People want to have a beautiful child. And I'm curious, what originally got you into IVF? How did you kind of get here in the first place?
As a physician, I think we owe it to our patients to be passionate about what we do. We shouldn't just be coming to work every day and like going through the motions. So when the pathway that led me to this field really also was a labor of love and a labor of my own interest and my own history. So I think what you'll find for many reproductive endocrinologists, first of all, is that most of us have some personal or family history of infertility. It has touched us in some way that at least has led us down that road. And then for me, was always interested in genetics and molecular biology. And so there were several forks in the road that led me down to this path that have been just the most wonderful turns of events that have made sure that I was on the right journey for myself. So when I was in college, I knew that I loved biology, and I thought maybe I was going to go be a researcher. And I stayed up all night counting dead fruit flies in a lab and decided that I would much rather interact with patients all day long. And then when I went to medical school, I thought I was going to be a clinical geneticist. So you probably interact with a lot of clinical geneticists. This was the field of medicine that I found so fascinating, taking care of mostly children and people with rare diseases and helping them to live their best possible quality of life. I also really loved the puzzle solving nature of it, getting down to the root cause of the molecular cause of any disease. So I thought I was going to go into clinical geneticist. Most geneticists are pediatricians. And it turned out that the field that I loved the most was OBGYN. And what got me out of bed in the morning, I had to go to Elmhurst Hospital in Queens to go do my OBGYN rotation in medical school. We had to leave on a bus at 5 o'clock in the morning. And I just could not wait to get on that bus every day. And I had really felt that I'd found my tribe, I'd found my people. And so going into OB was just such a natural fit for me. OBGYN is a wonderful field. There's so many things that we do to help women. We take care of gynecologic cancers, we deliver babies all night long. But the molecular aspect of it is the reproductive endocrinology field. And so to sort of bring me back to my interest in genetics and the root cause of disease, I found this subspecialty, and it has just been the absolute best fit.
Wow, that's amazing. And I read that you had identified a genetic mutation that previously caused some sort of familial infertility. Want to talk a little bit more about that?
Yeah, so this was a case, and what's really interesting, I think that you sort of have a similar, even though you're a lot younger than I am, you have a similar path where you also feel that you grew up as the Human Genome Project grew up.
Yeah.
And so for me, as an undergraduate, I had done research where we were sort of data mining the original Human Genome Project, where I remember when there was only 1 and then 2 sequences that were available for us to work with. And then as I progressed through my training, the science of genomics progressed so much. And then even though I was in clinical medicine and not in research, in our subspecialty, we learn how to be scientists. You cannot be a reproductive endocrinologist without having the basis to understand and critically evaluate all of the research that comes out in our field. So we have to do research projects in fellowship. And so the project that I did was a whole exome sequencing project of a familial case of infertility. And it was a case of an FSH receptor mutation that had previously not been characterized. And so what I did was just the data mining from the sequences and then actually the functional studies using flow cytometry to show the actual sort of how much function this particular mutated FSH receptor has. I mean, it's all very cerebral. And unfortunately, even having the root cause of that family's genetic infertility doesn't necessarily give us a treatment for it, but it is a heck of a lot closer than if you didn't even know what the cause was. And so it's really just it's sort of the two sides of the coin of clinical and research medicine, is just how beautiful it is to really get to the root cause of things, and how, at least even if you can't necessarily treat something right now, at least people know that you've diagnosed them properly.
Yeah, so that's pretty amazing, because it seems as if in your career you actually touched a lot on genetics. And so it's amazing to see how, to your point, the Human Genome Project, it's progressed and evolved, and now we're bringing kind of frontier genetics to the clinic.
Exactly.
It's pretty cool.
Yeah.
I have a question for you, which is, a lot of patients ask us about IVF, and the media also covers IVF a lot. And what I find is that there's a lot of misconceptions and misunderstandings. And I'm sure you, given what you do, talking to patients every single day, hear it all. And I'm curious, what's the most common myth that a patient comes in to Beverly Hills Fertility? What's the most common myth they have about IVF?
Well, I'm going to back up a little bit and explain a little bit more about why IVF is necessary for next level and next generation embryo testing, like what Nucleus is doing. And so, you cannot test embryos unless you have embryos to test.
Yes.
And so the thing is that, first of all, as you've talked about, and as I firmly believe as well, I think we're probably only about 50 years away from having eggs and sperm, human gametes, that are made from stem cells. Yeah. And we are going to, we are no longer going to be limited by a woman's supply of eggs. We're now going to be able to make eggs for a woman who already has menopause or premature menopause, or...
And you see that future coming?
Oh, for sure.
Yeah, 50 years, you think? I'm just curious.
Yeah.
Okay.
And we're going to be able to take 2 sperm and or stem cells from 2 men and differentiate one into an egg and one into a sperm and make a baby. And so these are definitely all coming. And once you have that, you can have libraries of embryos to screen. And the ethics of that are going to deserve a lot of attention, because you can make human evolution probably happen at rapid speed once you start screening libraries of embryos like that. Right now, we are limited by what a particular patient can produce. And we are especially limited by not only the genetics that you're talking about testing, which is a deeper level of assessment of someone's polygenic risk scores, but actually we're limited just by simple chromosomal number, copy number status. And as women get older, they have fewer and fewer chromosomally normal embryos. And so something like a nucleus testing for embryo screening this is a game for the young. And as we get older, we are going to have fewer and fewer even chromosomally normal embryos from which to choose. So if someone is interested in availing themselves of newer technology, they really need to be thinking about it when they're younger than 35. So that's one important thing. You also can't, no matter how old you are, you can't have embryos to test unless you have a really excellent IVF cycle. You have to have the best possible treatment that is possible for your body. It has to be personalized. It has to be tailored to exactly what you need. So a couple things. I think one of the biggest myths about IVF is that it has to be drawn out and terrible, and that the meds are so horrible, and that you're going to feel so bad. And I think that if you keep your treatment protocols simple and evidence-based and personalized, and you explain everything with clarity to your patients, they are no longer going to be kind of stewing in the dark of feeling like you're the worst. I hate it when they say, you're going to pump me full of hormones. It's like, what kind of monster do you think I am? Like, I am a doctor trying to help you achieve the goal that you want. And also, if you're so wary of the treatment, don't do it electively. So, you have to trust that people are doing the right thing for you, and this has been tested, and that it's safe, before you go down this road. And so if you keep your treatment protocol simple, and you make sure that you have an open line of communication with your patient so that she can ask even the littlest of questions are the ones that people stew in, they're gonna feel a lot better emotionally and physically. There is another big myth about fertility treatment, and that is that it's a marathon that you need to try over and over and over again for it to work. And I think there are some cases that can be like a marathon. And in those cases, your doctor should be very honest with you that you have a good chance of this working if we just do X, Y, Z in this order, and we keep going and we keep trying. On the other hand, the majority of cases should be easier than they're made out to be. Good, simplified standard of care medicine should treat the vast majority of people. And I think that a lot of sort of the Instagram influencers out there who talk about doing 15 retrievals and 15 transfers are really doing a disservice to patients, because we shouldn't be doing that many retrievals and transfers without success. If people are doing that much treatment, it's because something is not working right for them.
So what I'm hearing from you is you're saying that a lot of patients might come into a clinic and think, all right, IVF has to be this long, difficult, like hormonal process. And you're saying that, if you get good quality care, right, you can do one cycle and you can have a child.
Correct.
Right. And so it's so important to choose the right clinic and the right doctor for that reason.
Yep.
And then in the context of nucleus embryo, you were describing something I think is really important to say, which is obviously in the context of nucleus embryo, we analyze embryos that exist.
Right.
And for that, you need viable embryos.
Right.
And sometimes people come to an IVF clinic and they just want to have, a baby. And, in that context, you help those patients. You also help patients who may have several embryos.
Yep.
And then those patients can do nucleus IVF if they want and genetically optimize and pick accordingly.
Yep.
And I'm curious, do you think that, let's say you had a microphone to every parent that is about to come to your clinic, and it's related to the misconception question, which is okay, whatever, n number of patients are coming to you, even before the end of the clinic, you could tell them one thing. What would you tell them?
Oh gosh, there's so many things. Just unrelated to embryo testing, just
just in general IVF.
In general about IVF. I would tell people that you have to live your life through this, and that this has to be a part of your life, not your whole life.
Okay.
And people ask me, and the worst is the husbands say to me, doctor, tell her not to stress. She's not getting pregnant because she's stressed. And I was okay, this is beyond. You can't just wag your finger at somebody and tell them not to stress. Of course they're stressed. They're not getting pregnant. They want a baby. And it's not the stress that's keeping them from getting pregnant. First of all, everybody is stressed, including your friend down the street who gets pregnant easily. And of course you're stressed if you're not getting pregnant because you wanted a baby yesterday. It's understandable. And so what I try to tell people to do is to proactively take the best possible care that they can of themselves through this. They have to live their lives. And part of that is not giving people this prescriptive, strict lifestyle thing to follow. You don't have this much agency over this. There's not some magical supplement out there. If you are a normal, healthy person taking good care of yourself, you should be exercising. A lot of doctors don't exercise. What the heck is that? No, you need to do what helps you stay sane. Exercise, a cup of coffee, go out to dinner with your friends, get a massage. We have to proactively take care of ourselves so that we can be the happiest that we can be during this.
When a patient comes to Beverly for Fertility, walk us through what's the journey, right? People always, it's sort of this black box the patient has. What's the first step to having a child? Walk us through.
So we're very thoughtful. I'm very thoughtful about trying to make the best use of people's time. And so I don't do unnecessary testing. This is not like a protocol based, everybody does the same thing. So that starts with the first step is even a suggestion about when to make your first appointment.
Okay.
So if I see a patient during a particular time in her menstrual cycle, so it's actually after her period and before ovulation, I'm going to get the best picture of both her uterus and her ovaries. And I'm going to be able to actually avoid doing extra uterine evaluation because I'm going to see it on that first visit. And so when I see people at that visit, what's super interesting is that if I see you before ovulation, so you're cycle day 6 to 12, my favorite way to start IVF is a luteal phase IVF start. So that's cycle day 18 to 25. So I literally could see you and you could be starting IVF 1 to 2 weeks after I see you. And so you could start IVF in the luteal phase, and then luteal phase IVF is the same as any other IVF cycle where it takes 9 to 13 days total. You get your eggs retrieved, and then if you're doing embryo testing, then you're waiting on your embryo testing results to come back. And then you can often do an embryo transfer your very next menstrual cycle. So you can go from consultation to pregnancy in 2-ish months. Yeah.
That's pretty amazing. So the first step is a consultation with you, with someone on your team, or?
Oh yeah, no. I always see everybody for a full hour when I first meet them.
Okay, so you see every patient that comes through?
Oh yeah. Well, anybody who's scheduled to see me. We have Dr. Thomas is here also.
Yeah.
But certainly everybody who is coming to see a physician. You're not coming to see a PA or a nurse practitioner.
Okay.
We don't even have on staff. No, you're here to see the doctor that you've made an appointment to see.
Yeah.
And so we then
walk us through that consult, right? An hour with you. What do you tell the patients? Walk us through that.
So first of all, it also is preferably in person.
Okay.
Of course, I have people who are coming from out of state or out of country, and those people I'll meet with remotely. But if you're here, you should really be in person, because there's something about building a rapport in person. And I don't know, some of you watching, you may consider yourself an empath. I am such an empath. I really can't stand remote consultations. I'm sitting there on the little screen and I am trying to emote with that screen. And I come away from that screen exhausted.
Yeah.
And so if I have somebody in front of me, I connect with them. And I notice, I mean, sometimes even months out, I'm like, I don't have such a great connection with this patient. I'm like, oh, right, her initial consultation was remote. There's something like that really gets built in that initial in-person hour that I find very, very important. There's a lot of trust and rapport that gets built. I also always do an ultrasound. So remember I talked about the cycle day, that's important. I'm gonna do an ultrasound. There's so much that I can pick up from an ultrasound. Otherwise, your consultation is completely hypothetical.
Yeah.
And I hear so many people switch to remote consultations during COVID and they never switch back. It's like, how do you have a completely hypothetical conversation with people?
Yeah.
You have to tailor their treatment to what you see on ultrasound.
Yeah, so you actually run tests, you talk to the patient, and then you do the most critical thing, which is emotionally connect with the patient, right?
Yep.
Right, because that is the foundation, it seems, of the way that Beverly Hills Fertility does their care.
Correct.
So after the consultation, then I guess depending on what you find, you then funnel the patient to different
for sure.
steps.
And it's not one size fits all at all. Not everybody goes straight to IVF, and you should not assume that, if you come in here wanting, there's many people who do, but there are many people who don't. And so there are definitely other things that we do to start. We get people pregnant with insemination, if they don't need IVF. And it's a very personalized conversation.
Yeah. One thing I'm extremely impressed with on the Beverly Hills Fertility front is just the facilities. I mean, wow, it blew me away.
Thanks.
You want to talk a little bit more, I'm not sure if patients, when they come, if they see the lab and they see all the areas, want to walk through.
Well, they can't, we got to keep it clean.
Exactly. Want to walk more through the facilities you guys have here?
Yeah, sure. It's a 12,000 square foot suite in a building in Century City, like right between Westwood, Beverly Hills, a few minutes from the highway, very centrally located. People can get here from all over Southern California very easily. We have our exam rooms. I see patients every morning in the examination rooms. All of our rooms where I do ultrasounds have big screen TVs, so you can see exactly what I'm seeing, and I can explain to you and teach you about your ultrasound. We do all of our own blood draws. We run our own endocrine, our own hormone testing in-house. So we get back all of our hormone labs, our IVF cycle, in-cycle hormone testing within about 2 hours every day, in-house labs, including your pregnancy test. So you find out pretty quickly if you're pregnant when you come in. And then, we have all of our doctor's offices here. And then we also have our surgery center. We have a full-time anesthesiologist and recovery room nurse so it's the same team every day taking care of you. We are constantly getting feedback that the warmth of our entire team, our medical assistants, the young women drawing your blood and rooming you and just forging and teaching you your medications and just forging a connection with you, that the vibe is so, so good. And also our nurse and our anesthesiologist are just so warm and so caring. It's really important.
So it sounds like you do everything in-house. All the staff is your staff. You basically, from the beginning to the end, run the entire process.
Yep.
It's empathetic, and this is all accurate descriptions.
Yep. And the lab. I didn't talk about the lab.
Yeah.
The lab is literally we do an egg retrieval, and the eggs are getting just handed to the lab, and then they're calling out 1, 2, 3. I know, I'm talking to the embryologist as I'm doing the egg retrieval.
That's amazing.
Yeah.
A question for you is, people are talking a lot about how birth rates are dropping. Do you have your own theories for why that might be? And then the next question there is, how do you think IVF plays a role? Thoughts?
Gosh, I feel that people are not necessarily connecting as well with other people. I think that people are kind of living their lives online a little bit more. Life and relationships are messy, and you have to sort of be out there meeting people when you're young, when you're, in high school and college, and figuring out who the right person is for you. And most people want to have a baby in, a relationship, and they want to be together. And I see so many single women freezing eggs, which is a great option for them. But it's usually because men are non-committal. And I think that people we have to kind of swing around a little bit to understanding that we don't have all the time in the world. you don't want to be a parent for the first time when you're 46 years old. Like you're parenting is for the young. There is a time in our life when we need to do this. We just have to bite the bullet and do it. And so I think that people are sort of living in this feeling like they can be young forever, and you can't. You just have to be a parent. You got to do it. There's no right time. Parenting is crazy. Like it's never easy.
Yeah.
You just have to do it.
Yeah. And so when you see couples coming through, I'm curious, you've been practicing for so long.
Yeah.
Do you see anything really different about relationships? I mean, like in a way, like, you know, you must know a lot about relationships because I mean,
I've seen them a lot.
You've seen them a lot, right?
I see good ones, I see bad ones.
Well, yeah, like
Not a mental health professional.
Maybe your question is like, what makes a good, like, what would be your advice? Like, what's a good relationship?
Just support, you know,
yeah.
supporting someone else in all of the messiness, you know, and knowing that like it's never going to be perfect, but like this is your person, and if this is who you want to have a baby with.
You would recommend a couple having children earlier? Like sometimes people wait until later on, but you recommend to have them like late 20s? Is there like a
I mean, late 20s would be a dream, but like 35, you know, please, you know, 35 is a world easier than 39.
Really?
Yeah, and it is just not that many years. Just bite the bullet and do it at 35.
Interesting. And wow, that's very interesting.
Yeah.
And so
medically, it's worlds easier. And I don't know, personally, I don't know. Like, you know, like, is your medically as far as getting pregnant and also as far as pregnancy complications, 35 truly is a world better than 39. But I mean, as far as like actually having that newborn, are you really that much more energetic at 35? Probably not. But like your body is better equipped to be pregnant and get pregnant and stay pregnant.
Yeah. So it's almost like saying that like it's not linear. It's
oh
like,
no, it is
jumps.
35.
Wow.
Yeah.
Okay, interesting. I didn't know that. So when you know, people talk about how the older you get, the more likely like your kid will have like autism, for example. What are your thoughts, perspective on this?
I mean, that does not go up so strongly with maternal age. It goes up with paternal age, but still not dramatically. Your family history of autism, I mean, correct me if I'm wrong because you're the geneticist here, but family history of autism is still a far stronger predictor than paternal age. And it also doesn't really go up until at least 45 and probably even higher than that. So I think that what people need to understand is that as you get older, it's not like you are at risk of having some nebulously unhealthy child. We don't accumulate little mutations in our DNA that make us have unhealthy or sick or unattractive or unintelligent children. If you get lucky and you are pregnant at 39, 40, 42, that baby is the same health as it would have been 10 years ago. It's just harder to get it. It's more like finding a needle in a haystack. It is an all or nothing thing. Is that, do you get that baby or do you not? Not that that baby is going to be unhealthy. Yeah.
People often talk about infertility in the context of women, but then men also, I read, can often be the cause.
Yeah.
How do you think societies understand that it is evolving? How do you talk to your patients about that? I feel like men might be a little bit more uncomfortable generally, but what do you think?
Sure. I mean, it's always, you know, there are very many cases of unexplained infertility. I mean, that's one of the most common causes that we see, where all of your stuff checks out on paper. And I tell people, like, look, your goal is not to have, you know, certificates that you hang on the wall saying that your fertility testing is normal. Your goal is to have a baby. And there are going to be, you know, there are molecular issues with some receptor on the egg or some receptor on the sperm or some little cilia in the fallopian tube that doesn't beat properly, you know, so like you don't know why a particular couple is having trouble, and the sperm are probably a big part of that. Now, I mean, is there anything we can really measure? Yeah, like, you know, like what's up with all the marijuana smoking? Like, what is it? Why is it that like fully 50% of the men and 30% of the women who walk into my office tell me they're like frequent marijuana smokers? You think this is healthy for your eggs and your sperm? Like, I mean, call me like a major nerd, but like, I just think that if you are trying to conceive a child, you should be living your cleanest possible life. And so I think that, like, yeah, the men need to clean up their acts and take antioxidants and eat really well and exercise and take care of themselves.
I mean, weed probably impacts fertility.
The data is very mixed. They've tried to study it. Sometimes they've even found that it's beneficial for sperm. I don't know. But I just like, the data is very mixed, but I still just can't.
Anecdotally, though, there's something that you feel.
I just can't.
Yeah.
Yeah.
And then so let's talk about the different kind of testing that someone does. So there's like semen tests, there's like preconception testing. I want to walk through like the different tests you do to kind of check the kind of health of both the mom and the dad.
Sure. I mean, what's beautiful about this is that like a workup is very simple. Like what I tell people is fertility problems are very common. You can have more than one problem in the same couple. So I need to know what I'm treating. So I'm going to do a whole workup. So what I explain is, first of all, I have sort of a checkbox item. Checkbox item is genetic screening. So what you want to do is do whatever you choose from the panel of options, whether that's a nucleus test or another genetic carrier panel. You want to at least do some investigating to see if you and your partner might have a genetic risk together of having a child with a condition. Whether it's something simple, Mendelian cystic fibrosis or spinal muscular atrophy, versus something that's a more polygenic risk score like what you guys are doing. And so that's a checkbox item. What I tell people is that these are low probability, high impact tests. And so, because if you find out that you and your partner are carriers of some severe, rare recessive condition, that is going to change what your plan for conception is. Because it's still out in the real world, people are not doing this preconception. So to follow this out, let's say I'm pregnant on my own and I haven't had preconception testing. So I'm a normal, healthy person and my OBGYN didn't even talk about it with me. So now I'm 11 weeks pregnant before I ever even do any testing with my OBGYN. She runs a carrier panel on me. It comes back 3 weeks later, and I'm a cystic fibrosis carrier. Yeah. Oh, don't worry, your husband won't be, it's okay. So they send his, although it took a week to get it drawn because they're dealing with whatever. Now his comes back 3 weeks after that. Well, now I'm 18 weeks pregnant, and he's a carrier too. And there's a 25% chance that I have a cystic fibrosis affected fetus that's 18 weeks of gestation that I'm already showing, and I'm telling everybody I'm pregnant, and I'm thrilled and I want to have a baby. So now I do an amniocentesis on my 18-week pregnancy, comes back a week later, now I'm 19 weeks pregnant, and my fetus has this horrible, cystic fibrosis treatments are evolving and they're better, but what if it's something really lethal like Tay-Sachs? So if spinal muscular atrophy is one that really people don't know about, also very lethal. So like I know people who have been in that exact situation, multiple people that have been in that situation. And so it is a devastating decision to terminate your 19-week desired pregnancy because you didn't get preconception genetic testing. So this is what we're trying to help people with. So,
Absolutely.
Yeah. So that was a tangent there. So that was the checkbox item. Then you've got sperm. Sperm are so easy. We don't even do semen analysis in the office anymore. And you can do this direct to consumer. You can get yourself a direct to consumer sperm test. Nice. Have at it. And then, I look at the uterus on ultrasound. I do not do extra testing if it's not necessary. Like I'm not following some protocol that everybody has to have a saline ultrasound. Hysterosalpingogram, which is an X-ray of the fallopian tubes, is actually an incredibly important, useful test in many circumstances. Again, person by person. If they're going straight to IVF for whatever reason, they don't need it. But it really is. It is a gold standard test, and people are moving away from using it, and they should not be. It is a really good test if what you need to know is if somebody's tubes are open. And then the most important thing is the ovaries. So I do a lot of educating people about age and chromosomal abnormalities and egg number and the impacts of age on their fertility and on their fertility treatments. And so that's really the workup. The workup is genetic carrier screening, sperm, uterus, tubes, and ovaries. And plus, like whatever unique thing there is about that particular patient. Some people are medically complicated and they bring to the table their own medical issues, and I work with their doctors, and there's a lot of collaborative efforts going on.
Amazing. Mm-hmm. One thing that people talk to us about all the time and is all the rage these days, so I have to ask it, is about AI.
Okay.
And I'm curious, at Beverly Hills Fertility, are you seeing AI actually change things for you guys?
I mean, there are so many different places that it can help. I mean, there are all these companies that want to try to become an AI reproductive endocrinologist. They want you to plug in all the patient's parameters, and they're going to spit out at you the protocol to use for this patient. They're going to monitor the patient. They're going to do, there's ways you can put an ultrasound in somebody's vagina, and it can just scan through the ovaries and give you all the measurements, as opposed to what I do, which is I sit there and I old school tap, 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 measuring my follicles. Because sometimes I think, is this also for me? Like, is this also like, am I doing this for my patients, but I'm also doing it because it is what gives me a purpose in life? And would I feel that purpose if AI was doing this for me? And I also don't think that my patients want AI. They want someone to to hold their hand, and they want someone to feel what they're feeling, and they want someone to emote with them. And for better or for worse, unfortunately, they want somebody they can yell at, which is like, please don't yell at me anymore. But like, sorry. But it's like, people just want like, they're not going to feel satisfied if a robot is doing their care.
Yeah.
And so like it's, I don't know if you want to leave that in or not.
But what you're saying is a really point, which is it's not just about technology, it's about empathy.
Correct.
And, I think people often miss that in the conversation about AI, which is like the job of a doctor.
Yeah.
Yes, it's that expertise, but it's also to hold their hand, especially in IVF.
Yes,
I mean,
exactly.
especially in this context, right?
Correct.
And so in that way, I think like your job and the broader team's job,
Yeah.
it's never ever going to go away. Of course not. I'm sure people listening to this podcast are probably wondering, how did we first meet?
I think that I have a husband who's active on Twitter, and you're active on Twitter, and something.
Yeah, your husband introduced us, which is pretty funny. But he's an ophthalmologist, isn't he?
Yep.
So my dad's an ophthalmologist, and he's
great.
Persian
And he's
as well.
Persian. Yep.
So of course, ophthalmologist, Persian. I mean, it's
There
just
you
a
go.
natural fit. Thank you, Dr. Goldstein,
Yeah,
for being
thanks for
on.
being here.